So good morning. I'm Paul Bittinger. I'm with Mass General in Boston and the Harvard School of Public Health. And I very much want to thank Masheed for inviting me to talk about disaster medicine and its relation to the work that everyone else is doing here. I find it particularly exciting as an opportunity to figure out what we can be doing, should be doing better with disaster preparedness in a data-driven way. I've worked with Chris Nelson at RAND for years on some parts of disaster preparedness, and I will say, unfortunately, a lot of what I do is really a data-free zone. That it's just ideas people come up with, sounds great, we put them into practice, and no one knows if they work. And I can't really do randomized control trials with disasters, with staying out of jail. And so what I would love to do is make the case that here, with a lot of the work that the ACRU is doing, is an opportunity to look at the acute care system under stress, which it is constantly, and extrapolate some lessons that might help us actually be better prepared for disaster overall. What we're going to talk about is how disasters affect acute care systems, because they really are stressors that put enormous pressure, of course, on acute care resources and show the fracture lines, show the faults even more strongly. And so if we look at where those problems are noticed in response to real disasters, potentially we can both improve care on a daily basis as well as overall improve disaster medical care. Talk about how changes in acute care are affecting disaster preparedness, and a lot of the data that I'll present will be very, very familiar to you all. I spent 10 years as the medical director for my emergency department at Mass General and felt these problems on a daily basis, but the ways in which we're challenged to deliver care on a daily basis actually make disaster preparedness harder and harder year after year, and then sort of tie it up for potential ways in which this could affect some of the research that's going on within the program. I always start with the basic definition of a disaster, which is that needs are greater than resources. And especially for any good emergency physician, that makes you smile and chuckle, because that's every single day in the emergency department. And really for most of us across the acute care system, that's what the reality of our life is that we have much more that we're asked to do than we have the resources to be able to do. But disaster preparedness, admittedly I'm biased on this, but is not just important now, but I argue is actually becoming increasingly important. That all these disaster events that you see on the news, and tragically obviously this morning counts, are not really just the CNN effect that they're broadcasting it more and more and more because we have more cable news and it sells whatever they're advertising that day. A lot of it has to do with climate and weather events, and some of this is tied into climate change. But that all disasters have a bigger impact on human populations. And some of it is because there is an increasing frequency of disasters, flooding, severe weather events, those kinds of things. Part of it is how we live. We are more clustered. We're more densely populated in cities. We're more coastal. We're living next to areas that flood. And so when disasters happen, the human impact is going up and up and up, and there's really a need for better disaster systems because the loss of life is extraordinary. The human toll is substantial. There obviously are increasing violent conflicts in different parts of the world, and even zoonoses, ways in which infectious disease travels from humans to animals or travels around the world because of our transportation systems are increasing, and obviously we have several recent examples of that in the news that you've seen. I don't want to overstate the terrorism part, even this morning's news notwithstanding, but there are more terrorist events, and the randomness of it means that although the likelihood of any one emergency department, any one of us being part of a terrorist event is really still extraordinarily low, they can happen anywhere. And again, we've seen this. But what it means is that systems have to be prepared, and you have absolutely no notice. And the fact that you're in San Bernardino or you're in Orlando or at the Boston Marathon, which no one would have thought was a particular terrorist target, or Manchester, England. Who would have thought, obviously, that a concert aimed at teenage girls would be a target for terrorism in, outside of London, England? That doesn't make any sense. And so I think the fact that we have to be ready for them, even though the likelihood of the events is low, is a really important message. And we see this not even just with terrorism, but with active shooter events. Lots of emergency departments, smaller communities get overwhelmed with active shooter events, which are clearly on the rise, though again, thankfully still extraordinarily rare in terms of their occurrence in any one community. So my whole job is to worry about everything and to be very scared about everything. And you can divide up all the scary things in a lot of different ways, but I think for the purposes of today's discussions, I want to talk about two kinds of ways in which disasters affect the acute care system and kind of what that means for the acute care system. So there are no-notice events, things that just happen. You couldn't have predicted them. You didn't know they were coming. And this can be obviously terrorism, but it can be a tornado. It can be an earthquake. It can be several natural phenomena. And it can be more sustained events that you have a little bit of warning, but it's going to stick around an awful lot longer in terms of its effect on the system. So if we talk about no-notice disasters, by definition, obviously, there's almost no warning. Maybe a tornado you'll see coming briefly, as they did in Joplin, Missouri, when a hospital was hit and destroyed. But basically, these things are somewhat predictable. They're somewhat understandable. There is an epidemiology to no-notice disasters. And so first, you may get a lot of walk-in patients before you get your more critical patients. And that sort of makes sense when you think about it. The most seriously injured can't run to the hospital. They have to wait for someone to move them, whether it's professional responders or bystanders who put them in the back of the car or the pickup truck. But the patients can show up very, very, very quickly. And one of the things we in Boston are most grateful for is that we spent a lot of the time in the few years after 9/11 preparing for disasters much differently than we had for the decades preceding. Most of the Boston hospitals, my own hospital included, thought that we had 20 or 30 minutes after a disaster happened in the community to kind of figure out what happened, how many patients are there, call in our staff, organize ourselves, get ready. Because you can't get anywhere in Boston in less than 20 minutes. And it seemed like that was the right amount of time to ramp up. And we brought in colleagues from Israel, from Mumbai, from London and Madrid, all folks who'd been through terror events. And they all told us that on average, between about 4 and 18 minutes is the average window for patients to start showing up. In Israel, on average, when there's a terrorist bombing, first bloody victim walks into your emergency department 4 minutes later after the explosion. Which sometimes precedes your official notification from fire, police, EMS. So folks walk in and then they start coming quickly. And that first hour is typically the window you get half of your patients. So again, in Orlando, 44 patients came in within the first hour. University of Colorado, when they had their shooting, more than 50 patients came in within the first hour. And so being able to take big, complex systems, Orlando, obviously the trauma center, University of Colorado's trauma center, turn on a dime and be able to take care of overwhelming numbers of patients in an extraordinarily short period of time, even big centers cannot deal with. And I was talking to some folks this morning. There is science and literature that says even among big trauma centers, after your 5th trauma patient arriving simultaneously, your quality of care goes down. And so how do we turn our systems on a dime with the resources we have? We're never going to have 4 trauma surgeons, 6 anesthesiologists just sitting in the wings waiting for that event that may never, ever, ever happen. How do you turn on a dime and still deliver effective care is what we work on. So some of this is a needle in a haystack problem. Lots of people come in, some are critically injured, some are not, and it's not always as obvious as you think. This is especially true, unfortunately, in terror because in bombs, as you probably know, they like to put shrapnel in the devices, and so these tiny little puncture wounds that don't look so bad can be the small wound that punctured your vena cava, your aorta, or something else. And so you look great, and then you go down. And we heard this again and again. When we, as a Boston community, brought in speakers from London, from Madrid, all the places I mentioned, they all had a tragic story of someone who was triaged as yellow or green, kind of put off in the corner because they didn't look so bad, their vital signs were good, they were talking, they just had a little wound, and that was the person who unfortunately was dead when they checked on them later. And so trying to find that 10 or 20% who are truly critical in the haystack of hundreds of patients can be extra challenging. Getting them care in a timely fashion is really, really important. When I was trained in EMS, and I got into emergency medicine in general because I was out in the field as an EMT, but this was back in the 80s, we were all taught to take all our red patients and kind of line them up in a red tarp so that we knew who we had, and then we'd distribute them and we'd prioritize them. And people were kind of quietly bleeding to death on that red tarp rather than going to the hospital where they really most needed to be. And so trying to figure out how to take care of patient populations, how to use your community resources well. For example, when you're in Orlando and the trauma center is 3 blocks away from the incident, but it's overwhelmed. It's got 44 patients and you don't use any of the other hospitals in the area. It's not clear that that's an effective use of your acute care resources, excuse me. And I absolutely, by the way, just to be perfectly clear, I'm not criticizing any responses or any events that have happened, but I think we lack knowledge about how to use the resources in our acute care system in a disaster most effectively. When do we start to shift from our traditional systems where trauma patients go to trauma centers to distributing patients in something of a graded fashion differently? So I briefly, just very, very briefly, want to talk about the marathon. Several of you have probably heard talks on this before, but I think it's again kind of an illustration of the challenges we face in our daily acute care systems. So as many of you know, it was at 2:50 p.m., April 15th, 2013, the two devices went off at the finish line of the Boston Marathon. Boston EMS took a couple minutes to figure out what was going on and notified us by radio 5 minutes later. First patient arrived in the back of a private vehicle, nearly pulseless, in front of our hospital 9 minutes later. So from first radio notification to first patient arriving, needing immediate resuscitation, 9 minutes. We got 6 patients that had to go to the operating room within 30 minutes, and 5 went to the operating room within 8 minutes of one another. And even though here, your big trauma center, you obviously deal with critically injured patients all the time, I would expect you almost never send 5 patients to the OR within 8 minutes of one another either. We certainly do not. And so it really was extraordinarily difficult. But what was especially difficult, so obviously tragic photos, what's especially difficult is taking care of this many patients in a busy emergency department. So I have a 49-bed emergency department, reasonably big, 97 patients in the emergency department when the bombs went off. That actually is light for us. We're usually in the 110, 120 range at that time of the afternoon on Monday. I have an acute area, that's where my sickest patients go in the emergency department. It's 17 beds. It had 25 patients in it. So the sickest place where all my patients that have strokes, heart attacks, you name the issue that's going on with them, and Margaret knows this well, having trained in our program, we have critically ill patients in the hallway. And it's overloaded, and these aren't patients that can be moved elsewhere, and then now you tell me, by the way, you're about to get 38 patients in the next couple hours. That's the stress of the acute care system. That's the challenge of disaster preparedness, trying to interface with emergency medicine. So we did, thankfully, have policies and procedures for clearing out capacity in our emergency department. And they worked pretty well. I would say they actually ended up working extraordinarily well because of some interesting improvisation. So we had a process with our nursing supervisors, our admitting office, our transporters, to take patients in the emergency department, if we ever had to make room for a disaster, as we did that day, to just send them up to floors. And the admitting office sent people with medical-like complaints, so chest pain, shortness of breath, went up to medicine floors. People with surgical-like complaints, belly pain, et cetera, went to surgical floors. And the teams on those floors were supposed to just find the patients and kind of catch up and restart the evaluation. And you can guess that's not a great system just because there are gaps in care. You can see that there's a lot of opportunity for error. What happened spontaneously is our internists came and immediately, just as part of our mass casualty response, showed up, said, tell me about this patient, great, and they pushed the stretcher away. And they took it over and took over the care of more than 30 patients that day. And so now, counterintuitive as it may be, our internists are a fundamental part of our mass casualty response, and it's something that really works great now that we practice it and keep working on it. Point is that we had some plans in place, we made it better, and we actually were able to make rooms open for all the patients as they arrived. Not a single patient did arrive to the emergency department without us having a team in a bed ready for them. We were able to decompress our emergency department. This is our volume curve, and I expect it looks a lot like your volume curves in terms of time of day and how far above your capacity. Again, this line just below 50 is the capacity of the emergency department. This is when we run out of beds. And you know, that's an almost everyday occurrence. Actually, these days, a couple of years later, the curves have even shifted up further, and there are many, many days by which we never, ever, ever have an open bed. So, what are some of the lessons? Well, I think from a research perspective, we're trying to figure out how you take full emergency departments, because for the foreseeable future, the acute care system, the emergency departments of the world are going to be full. And how do you make them do everything they need to do within 4 minutes, within 9 minutes, within 15 minutes to be able to care for disaster victims. And we believe strongly that this is about prescripting actions. Most disaster plans, even mass casualty plans, involve calling a lot of people and then letting them figure it out, right? Call your surgeons, call your anesthesiologists, call your leadership, and then they'll organize and they'll lead. And it's our firm belief that that's not enough, that you actually have to be extremely scripted, that it's these 6 surgeons must come in and do this. This number of blood coolers must arrive here. These number of ORs. We are very, very prescriptive in our mass casualty plan about exactly what has to happen, and we set very, very tight time targets. 5 minutes, 10 minutes, 15 minutes. We have to open up X number of CT scanners. X number of radiologists must be mobilized. And we think that's what it takes to respond to a no-notice event. And we think that if you look at the true epidemiology of disasters, if you look at mass casualty events and the patient care needs, you can actually come up with protocols. Now, the challenge is getting enough data to prove the validity of those protocols, and that's one of the things we're working very hard on. It's a broad hospital effort, and I think one of the mistakes that a lot of hospitals make is assuming that mass casualty response is really only the province of either only the emergency department or emergency department and surgeons. And we firmly believe that's not the case. You need everything. You need your ICU leadership, you need your bed management leadership, pharmacy, radiology, you name it. At least in our experience, there's not a group on there that was not immediately touched by our marathon response, and groups that don't have to do very specific things. We found our blood product mobilization processes were insufficient. Our patient registration systems, I'll say more about that in just one second, were insufficient. And everywhere there's a little gap in your system, this is sort of the theme of what I'd like to say, everything that's a little hard on your daily basis becomes extraordinarily hard in a disaster when you have to do things faster, bigger, for more patients. So just as one example, we relatively recently had been transferring our information systems over to Epic. We hadn't completed it by 2013, but we were sort of in that planning process. And they were slightly cumbersome pre-Epic, they were moderately cumbersome post-Epic, but what we found is that in the disaster, we really had troubles identifying, tracking, registering our patients. And if we go on paper, it makes the entire rest of the acute care stay difficult, at least for the first 24 hours. And so the labs can't be reported well, they have to be called in, patients end up as medical record numbers, not as names. It gets extraordinarily difficult. And so what we do, again with the crucible of disaster preparedness to work with, is we try and hone down all of the processes to be as efficient, to be as error-proof as possible. And interestingly, our overall ED registration time, our patient throughput time in the emergency department have sped up as we have improved our disaster registration times. And so as you work on these potential needs to surge, you sometimes can improve the quality of care, the throughput in your organization otherwise. So I just want to say a second about sustained surge disasters because they're different. I think, frankly, in many ways, it's much more likely that all of us are going to face sustained surge disasters than face a mass casualty event or an acute surge disaster. And you know, by far and away, this most likely event that's going to cause us a sustained surge is going to be an infectious disease event of some sort. Flu, of course, is probably the most likely organism. It's so mutable, and you know, pandemics, hard to know on average, maybe 3 per century if you look at it, but it's so unpredictable. Could be this year, could be not for 50, but a big deal. We have seen, of course, the coronaviruses, SARS, MERS, there are other emerging infectious diseases that we've seen. And even though certainly none of us probably thinks that Ebola ever was going to be a sustained outbreak in this country, just looking at the impact of the possibility of an Ebola patient on the operations of the acute care system and how clinics, emergency departments, urgent care centers were paralyzed by that possibility of an Ebola patient coming to their doors, and what happened when someone who'd been anywhere in Africa showed up with a fever was, I think, enlightening to show how ill-prepared we are for emerging infectious disease outbreaks. But you know, lots of other things can cause us to have a sustained surge. You know, Hurricane Sandy, when it took out an enormous portion of the emergency department care capability within New York City, island of Manhattan really was hard hit for a long time. That creates a sustained surge, no question. Obviously, heat issues, cold issues, infrastructure, if you have water contamination, food contamination, all of those issues. But I think, you know, when we look at how we do more with what we have, it's interesting to revisit some of the literature that really has been dormant for almost 10 years. When everybody was worried about bird flu back in kind of 04, 05, 06, people were doing all the modeling of what would happen if we had a flu pandemic like we had in 1918, world's worst pandemic, or even the milder pandemics like 57 or 68, and look at the surge that maybe that would create in the US healthcare system. What's interesting is if you look at some of these numbers, they maybe don't make sense unless you think about what we currently have for resources. So this is indeed over the course of the pandemic, and so the pandemic goes maybe 8 to 12 weeks. So, you know, understood that these are not one-time shots, but look at the need for 700,000 ventilators. And how many ventilators are there in the United States? Anybody have any idea currently? Yeah, about 10% of that, so about 77,000. And that's ventilators of all kinds. So that's not even the full function ventilators, that's some of the lower functioning. ICU beds, almost the same number, so about 77,000 ICU beds. And so we are extraordinarily under-resourced for a 1918-like strain. Now, again, that's extraordinary. That's the worst ever. That may be too much of an extreme. So if you back off and say, well, we've had milder pandemics in 57 and 68, you're still seeing enormous numbers. And it's not as though, okay, we can take a lot of reassurance. We have 77,000 ventilators. Only 64,000 people need ventilators. There's a mistake that people often make in my world, which is we assume that no other disasters, no other medical illness is going to happen during the disaster. And so we can shift all of our resources over. And that, of course, is clearly not the case. And so trying to figure out how we accommodate all the needs for ongoing care as we accommodate a surge is really the challenge. And this is where the planning targets are hard. No one, of course, has a crystal ball. No one can really tell you what we're planning for because the threats are so broad and diverse. But it's not unreasonable to assume that in an infectious disease scenario, emergency departments may have to double their volume, maybe triple. Some of the emergency departments in New York City during H1N1, during 2009, when there was sort of the greatest panic, particularly among the pediatric populations, we're seeing truly 2 times their daily volume. And I don't know exactly how it is here, but it scares me a ton when I think about trying to see twice the number of patients in my emergency department that we see now. A 10% bump is extraordinary for us. Inpatient beds. The national Israeli planning target for disaster is take your licensed bed capacity and add 20%. And figure out how you can take care of that. And I think even when you think about that, that's an extraordinary challenge for acute care. How do you take a full system that's already operating at capacity? We know what operational occupancy is in most hospitals, and how do you add 20% to that? And ICUs similarly. Depends on the threat, of course. We all expected a severe influenza pandemic before 2009, and we got kind of an outpatient pandemic more than we got an inpatient one. But if we do have something where it causes surge in critical illness, looking at doubling your ICU capacity is again, almost extraordinary. And it gets really tricky, not just ventilators, but even your oxygen piping. We found in our own hospital that the areas we had planned for to have surge ICU space actually just don't have large enough oxygen pipes to be able to accommodate ventilators. And so thinking about how you surge gets to be very, very nitty-gritty. So I'm going to quickly go through this because I don't want to take too much time, but we know, and this is very familiar data, some of you actually contributed to this data, that the world in which we're delivering care is different, that emergency departments can't just be turned off. We can't just send all those non-sick patients home that we all seem to hear about on the news, that no one really needs to be in an emergency department anyway. And so if you look at the fact that the emergency department volume continues to rise at basically twice the population rate, the fact that some EDs are actually continuing to close in vulnerable patient population areas. Patient demographics are changing, and I'm sorry, I'm going to blow through this pretty quickly, but they can't be seen in their PCP offices. There's a lot of data that says PCPs are at capacity. They don't have much room to accommodate an acute care surge, and so even in an infectious disease event, a lot of patients can't really be shunted from EDs there, or the PCPs can't pick up the extra capability. We also know that the complexity and acuity of ED patients is continuing to rise. There's a fair amount of data that shows that because outpatients are sicker, therefore ED patients are sicker, and the role of an emergency department within the acute care system is changing, and a lot more is being asked of emergency departments as well. So yes, maybe only 10 or 15% of emergency department visits can be classified as truly emergent, but the number of critical patients who are within that 10 to 15% and the length of time they spend in the emergency department, I think we'll talk about that later today, is rising. But actually, and this is preaching to the choir a little bit, you all know this data, the number of patients who are truly non-urgent is actually really, really small. That the non-urgent visits to the emergency department are probably 7 to 10%, and it's not because it's convenient, and therefore you're left with 3/4 of emergency department visits which are necessary, which are complex, which require quite a bit of work, and therefore can't really be readily displaced to any other portion of the acute care system. And so in the middle of a disaster, trying to ask yourself, how do we continue to take care of this majority of ED patients while we are trying to surge, I think is a challenging one, because I'll tell you, most of the modeling of disaster planners is that, well, yes, we can just use the emergency departments for the really sick patients during a disaster, and we'll just ask everybody else to stay away for a while. And Art Kellerman and others obviously kind of summed it up very nicely with this quote, that we really are the central staging area for both acute care patients, but also complex patients. And so what does this really mean? this is my, everyone's favorite 2006 report that still I don't think made the splash that all of us would have loved for it to make in terms of congressional or other national intervention for access to emergency care. But it's the future of emergency care, the IOM report that came out, and in the disaster section, they actually put the copy of the U.S. News and World Report from the day before 9/11, which said that there was a crisis in emergency care, that access to emergency care was a problem, and this was known before the era of modern medical disaster preparedness, which really did start with 9/11 came. And they asked the question of, if we can't take care of our patients on a normal day, how are we going to manage in a disaster? And I guess that's the question I want to ask to you all. Mine is even a more level. I don't even have an R01 that I'm presenting here. I'm just presenting sort of a concept. But the idea is that in acute care research, I think including the questions of disaster preparedness, how do we take all those interventions we're trying to do to make access to care better, efficiency of care better, quality of care better, if we include an additional question, which is, and how do we do that in the extreme setting of disaster, of surge, whether it's no notice or whether it's sustained, I think we're going to maybe make better progress in improving disaster medicine than we have in a lot of other venues that have been really not even qualitative research, but more sort of, as a friend of mine, Mike Stoto from RAND, used to say, the BOGSAT method, which is a bunch of guys sitting around a table. So that's my set of comments. I think the point is our systems are at capacity every day, and things that don't work well during a daily effort will really not work well during a disaster. So I think there's some good mutual benefit. Really want to thank Masheed for the opportunity to join you, and I'm really excited to be a part of this program as well. So there you go.
So, Paul, that was a great talk. I know that you were talking about, unanticipated disasters, but I was wondering if you could comment a little bit, from like Boston, Bapu Jaina's paper on acute myocardial infarction care around the time of marathon. So is there a way we can learn maybe from kind of planned surges and how we handle those?
Yes, no, great. So really good question. I think many of you have probably seen the article, but Bapu, in a recent New England Journal article, showed that community mortality from acute MI goes up on days of marathons in the community, not from the marathon runners, but because of likely road construction, other decreased access to care, EMS transport times went up, other things. I don't have access to the Boston data. As you know, it was multi-center across multi-cities. I still think if I could ever see the Boston data, we would be good. We 9 months out start planning with our state city health departments. We have an extraordinary amount of community health planning. And not surprisingly, I've done a lot of talks on the marathon around the country, and I've not heard of another community that does that. And so I think part of the answer is pre-planning. I think you have to have an enormous investment in pre-planning for planned events. And so, we even have tall ships coming, which is a big event for us. That'll get 1 million people. But 4th of July, marathon, tall ships, you name the event, we convene a broad health community of hospitals, public health, EMS, other stakeholders, and really do both a lot of contingency and access planning that I think puts us in good stead. And clearly, if we're honest with ourselves, though we're really proud of the outcomes from the marathon day for a terrible day, the reason that anyone who was transported from the scene lived is half, and I'm making up the number of course, but half what the community had, half good luck, that things just happened in a certain way that was very good for the victims of the marathon for their survivability. But the fact that we are pre-planned, the fact that we put as much effort as we do into it, I think means a lot. I think the hard thing is that most communities find it difficult to mobilize the number of resources. They don't take it as seriously. And therefore, if something happens, or for the traffic issues like Bapu's article, you don't think about the impact on access to care.
Can I ask one follow-up, actually? So, I heard Peter Moyer years ago give a great talk about how, it took a lot of effort to get, originally, some of the Boston hospitals to participate in a primary PCI program. Okay. And so, because my understanding of the Boston marathon incident was that actually prior to that, you had gotten the Israelis and lots of other groups. So what prompted that? Was it just that you guys...
So Peter Moyer for many years was the medical director for Boston EMS Police and Fire, and just a fantastic emergency physician. In the 80s, he brought people together in a non-competitive way for disaster preparedness. And unlike PCI or surgery or any, disaster is non-competitive, and so we can actually share a lot. No one's being marginalized by that. He started getting people together for a community back in the 80s, and we had such a robust planning community that's actually mostly where it came from. Now we had a little bit of CDC funding to bring some of those folks over, so we did need some federal help for the speakers. But it's a similar program that was replicated in several other cities. They kept riffing on A Tale of Our Cities for the name of the program. And I don't know, and I don't mean to only sound like I think Boston's wonderful, but I don't know of another city that quite embraced the recommendations the same way in terms of changing their EMS destination protocols, some of the communication systems, some of the hospital trauma protocols. And I do think you need a community to do this. No one hospital certainly can do this by themselves. The EMS hospital link, back to your wonderful comments, I think is really, really important. So. All right, thank you very much. Appreciate it. Yeah.